Mr. Brian Stengel, are you ready?
Yeah, I am. I have two logins going, so I'm trying to do the slides on one and the microphone on the other.
Let me just interrupt. I'm sorry. We've given Brian 30 minutes because he has a really cool topic and he's really passionate about this topic. So he actually has 30 minutes.
Okay.
No break? I don't get a break in between. Okay, well, I guess I can get going if everyone's ready.
Okay.
It's that time. Let me see if I could share the screen. I don't use Zoom as much as I should. Here we go. Okay, so basically, I'm a substance abuse counseling major and dual majoring in psychology as well. Since 2019, I've been doing a heavy research on this topic, and so I have a lot to cover. I'm going to try and talk as fast as I can. Hopefully, y'all can keep up. Basically, what I've been studying is the opioid epidemic in general, aside from alcohol and drug addiction. So, getting started to go over the important statistics with the opioid epidemic is these are all reports from the CDC that I actually verified last night. So they're pretty up to date. And accordingly, as it stands, more than 130 people die from an overdose every day in the US. At the 12-month ending at April 2021, more than, actually it was 100,306 people have died from drug overdose. And those are reported. That's just reported. So that's an underestimate by far. Of those who died from drug overdose, over 75,000, 75% basically were opioid related deaths. We know fentanyl has made a huge impact on these numbers, and including in every drug category. So basically people who are dying from cocaine and meth and drugs not generally associated with opioids, they're finding fentanyl in their systems as well. So fentanyl is really infiltrating all drugs. Annually, opioid misuse costs the United States $7.8 billion every year. And surprisingly, this is from a survey from a few years ago. Roughly 10.1 million people aged 12 and above abuse opioids in 2019. So it's kind of scary. To put that in perspective, I have a graphic here. We can see here at 2013, it starts to spike as far as synthetic opioids. By 2019, we're at 36,359. If we look back 20 years to 1999, there was only 730 deaths from synthetic opioids. That's primarily fentanyl. So as of 2013, when fentanyl really started to kick off in the United States, that's when it started getting bad. What I'm going to be covering is a form of harm reduction. So what is harm reduction? Harm reduction, according to the Harm Reduction Coalition, is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It's also a social movement that respects people's rights to make informed decisions about their health. It enables people to better manage their drug use. It supports abstinence for those who choose abstinence. It reduces the spread of disease through safer practices. It also has the principle of meeting people where they're at in life. Instead of forcing a person into recovery, harm reductionists are meeting people in the midst of their addictions and encouraging and providing support for them to get out of their addictions when they're ready. And so on that note, harm reduction considers both the actual using as well as the conditions which a person is using in. And that's where we get into some examples of harm reduction, which include syringe or needle exchanges, on-site drug testing for purity and adulterants. And I'll get back to that in a second. Naloxone distribution networks, which the naloxone is the life-saving drug that reverses the effects of opioid overdose. They also include wraparound medical services, such as wound care, as well as professional training on safe drug using practices, community mental health referral programs, homeless outreach, intervention, referrals to medication-assisted therapy, and rapid response overdose prevention programs. And that leads me into my next slide. What we're looking at here, this is the naloxone. This is what is used, generally 4 milligrams. But because fentanyl is so potent, we're now, the FDA has actually approved an 8 milligram version of this because the 4 milligrams is a single dose. 4 milligrams are just not cutting it. They're having to dose people multiple times to bring them back from an overdose. This is the drug testing. These are basically just like litmus strip types of drug testing. They're fairly cheap from factory, but the availability is very limited. And I just looking for them around Silver City, I was not able to find any outside of the Department of Health. That's concerning. So what I'm going to call the rest of my speech is about overdose prevention centers. There's several names that have been used, and that's the second half of the lecture. But according to New York City Mayor Bill de Blasio, overdose prevention center services offer safe, clean places where people who use drugs can access clinical care and other services. The first SCS or safe consumption site in this case, or overdose prevention center, like I said, there's multiple names, began in 1986 in Bern, Switzerland. At the moment, there's more than 120 sites operating in 12 different countries. Every safe consumption site has a proven history of reducing the spread of HIV, hepatitis C, STDs, as well as reducing ER visits. Clients, according to the numbers, clients are 30% more likely to utilize add-on treatment services, such as detoxes and other services that introduce them into the paradigm of recovery, as I call it. Now, the public benefits also outnumber any negative side to it. So with the public benefits, we're looking at less hazardous litter. So there's syringes and things like that. People are not throwing them away. These places provide a place for them to safely dispose of these type of things. Public intoxication has been proven to be less. Public disorder, crime, and the amount of money saved is enormous. It's very significant. Basically, over the past more than 35 years, not a single life has been lost in any of these safe consumption sites or overdose prevention centers. Not one. Now, if we put that in perspective, had the United States done this, I guess I should let you know, we didn't up until a few days ago have any of these programs. So had we started doing this in 1999, when we started tracking the deaths from opioids, we could have saved upwards of 840,000 lives. And some research translates that into years of human productivity. So at 841,000 lives, that translates to approximately 28.6 million years of human productivity lost to opioid addiction and deaths. This is a picture of Insight. This is the first Canadian safe consumption site or overdose prevention program. As you can see, it's very sterile. It's very hospitalized. It's located in Vancouver, British Columbia. This is a mobile outreach safe consumption site. So these guys go into the communities. And this is one aspect I'm really pushing for here in New Mexico. Because as far as I know, we only have one or two, and they're both located in Albuquerque, which doesn't do any of the rural communities of New Mexico any good whatsoever. Here's another couple examples. These ones are from Montreal. The name is French. I'm not sure how to pronounce that. L'Anonyme. Anyways, they go around their schedules, 11 to 5 a.m. They hit 12 different neighborhoods per shift. And they also offer on-call services. So these are bringing the harm reduction to the communities as opposed to making the communities seek out harm reduction, which is not the way it should be. Of course, as I said, the U.S. has zero government, but it changed 2 days ago. I'll get to that. We have now, to my count, 2 government authorized sites and 1 underground site that is not operating legally. And so I couldn't do much research on that. According to the argument that has been used historically, the crack house statute is an old statute back from the 80s. And it really is antiquated, and we need to get more or less get rid of it. So back in 2018, nonprofit organization called Safe House. They plan to open a safe consumption site, and they're a Christian group whose primary aim is to save lives. However, in 2019, U.S. Deputy Attorney General Rod Rosenstein, he threatened to prosecute anyone who opens a site, and he cited the crack house statute. Ironically, our now President Biden was principal to making this statute happen back in the 80s. So I'll be happy to see if he manages to reverse it. 2021, New Mexico unanimously voted 7 overdose bills to Senate. Sadly, they all died. The one I was tracking was House Bill 123, which was going to facilitate basically legalize these overdose prevention programs. July 6th of this year, Rhode Island, they legalized the first site, and they actually called it the harm reduction site. So instead of the safe consumption site, provisions, they're slated to be effective on March. And then 2 days ago, New York opened the nation's first 2, and see, they're using a different name. They're using overdose, overdose prevention centers. So they opened the nation's first 2 overdose prevention centers in Upper Manhattan. As far as I know, they haven't been pounced on by the feds, but we'll see how that goes. The reason why we're having such difficult times with the drug war in general is because of stigma. Stigma goes back to Harry Anslinger when he started this whole marijuana scare and Dr. Fritz would know this because I've actually talked to him about this. And as you can see, that marijuana is the most violent causing drug in the history of mankind. That sets the precedent for stigma as a whole. Many of us know that what he said there is simply not true by any means. Today, this is what stigma looks like. And I don't know, some of you might remember, this is your brain on drugs. And then I found a more modern one that is vaping makes you a lab rat. And this one in the background is this mouth brought to you by meth. And you can't see it very well, but he's missing all his teeth. And so these are the myths and the lies that are being spread in order to create this stigma to perpetuate the drug war. The United States has been very active in spending money on researching this topic, just not in the United States. So I verified all of this myself. Spending by the United States National Institutes of Health. I found 3 grants. From 2007 to current, the research was all on safe consumption sites. The award recipients were all Canadian teams at the University of British Columbia. The total tax dollars spent through 2020 was $14.17 million. Total dollars paid to University of British Columbia, mostly for addiction studies since 1998, is $115 million. Canada's Access Study, which deals with these safe consumption sites exclusively, has been in progress since 2005, and it's 100% funded by the United States National Institute of Drug Addiction. Their VITAS study is also partially funded by NIDA. That study started in 1996 and is up to current. So we've actually been paying for quite a bit of this research, and yet we still have nothing except for a couple of days ago. One way that we can pay for it, because obviously money is of major concern. How are we going to fund all this? Well, this is how. Big money from Big Pharma. We know that Purdue Pharma and Johnson & Johnson, not Johnston, but Johnson & Johnson are the 2 primary high-strength opiate providers. Not coincidentally, they're also the providers of the medications that cure and prevent overdose. How does that work? So did they create a need for their medications? They got people hooked on opioids, and now they're making medications to get people unhooked. So it doesn't make sense in my mind. But court settlements as of May 3rd of this year, I counted up, is $48.31 billion. As of July 21st, you can add another $26 billion on top of that. All combined estimate is $74 billion. However, the problem is these companies are claiming bankruptcy. And so it doesn't really matter. They're getting ordered by the courts to pay all this money because when they go bankrupt, it wipes their debt off of the slate. So they get away with it. And then the other problem is that historically, and we can see this with the tobacco industry and the lawsuits that happen with them, where money was allocated that was supposed to be for rehabilitation and so forth, but it didn't go to where it was supposed to go. And it ended up buying police uniforms and a lot of things that many people argue are not exactly what it was designed for. All of this research culminated this summer in a fairly major project with Dr. Johnston and I, in which we wondered what is the problem? What's the holdup? Why don't we have these kind of sites? And what we figured that is that there's lots of different names that the sites are going under, and they seem to change with the tides. What we wanted to know is how do we frame this? What happens when we frame this in various different ways? And what we were trying to measure was the public support for safe consumption sites based on either one of several different variables. So, like I said, how does framing impact public perception and support of a community harm reduction program? The harm reduction program I'm referring to is safe consumption site. And these are statistics. So the United States is now amid its third wave of opioid epidemics, costing thousands of lives. Yet not a single, until 2 days ago, government-supported safe consumption site is available. These sites have been operating for more than 35 years in 12 different countries, outputting volumes, lots and lots. I mean, I couldn't even touch since 2019. I've really been digging into this, and I still just have barely touched the tip of the iceberg on this. And I've literally gone over hundreds of reports and research papers. Some believe that a major contributing factor to the absence of safe consumption sites in America has to do with societal stigma, which I went over before, again, against people who use drugs. This research that Dr. Johnston and I performed expounds upon the notion that if overdose prevention programs are properly framed and presented to the public, the stigma can be overcome. Consequently, we can pave the way for more safe consumption sites and other harm reduction measures to become a staple throughout the United States, which FYI, they're not. They're very spotty in many places. And in fact, here in Grant County, we don't have hardly what you would find in a major metropolitan area. The research that we studied, this research overview, I performed the initial literature review and evaluation of the findings and limitations of the prior research. The research question and preliminary hypotheses we developed, and then we made a conceptual design of the study and presented it to the Institutional Review Board. Upon approval, we fine-tuned some modifications and began recruiting participants. Then during the focus groups, we planned on doing 3 audio recorded focus groups and an online focus group, or an online survey is how it actually ended up. We collected the data, cleaned it, coded it, and it's still currently being analyzed. So what I'm going over here are not final results. They're just trends or speculations kind of as to where we're headed with this. The discussion's conclusions, limitations were notated and drafted, and we're in the process of putting together a peer review article for publication. The variables of the experiment, we have the controlled variables being the program name. So we have the safe consumption site, we have the overdose prevention site, the safe injection facility, and we added also harm reduction centers after Rhode Island legalized, and under the name of harm reduction centers. We kind of wanted to know what the public would think of that as well. So the description of program was also a variable. So we provided a small description of each program, the SCS, the OPP, and the SIF. We associated images with each, and all 3 were assigned an underlying theme. The overall framing that was the independent variable, and that was either as promoting safety through safe consumption sites, saving lives through opioid or overdose prevention programs, or scientifically proven safe injection facilities. So these are the 3 ways we framed each presentation. The dependent variable was the degree of favorability measured on a Likert type scale. And then I think we used another scale in the online survey, as well as a Likert. I think it was a 1 to 10. We had 4 hypotheses we went into this with. And our first was that the overdose prevention program and safe consumption site packets would be rated more favorably than the supervised injection facility packets. Our second theory was that, our hypothesis rather, was that the overdose prevention packets would be rated highest among liberals and and people with the most personal or familial history with opioids. This is my theory, just from my personal experience with addictions throughout my life course. So then the third theory was safe consumption. The safe consumption package would be rated highest among conservative people and people with the least personal familial experience. And we were basing that on, we figured that the more conservative people would be taking a more safe approach, if you will. The focus groups, then we figured that the focus groups, they would probably lean more towards the medical nature of these rather than safety and scientific reasoning. The first phase, the focus groups, came in 4 steps. The first step, we found in-person participants. They received a script, a verbal orientation, and written informed consent was obtained. Then the second step, participants opened and reviewed a framing pack. And that was followed by a 15-minute Q&A dialogue where they were able to discuss amongst themselves what their thoughts were and get any sort of questions answered. We tried to stay as far in the woodworks as we could on this in order to not in any sort of way influence their decisions. Each focus group was randomly assigned a packet. So that was the randomness that made it an experiment. The third step, then we asked them to rate the degree of favorability on a scale of 1 to 100. And in the fourth step, after steps 2 and 3 were completed for all 3 packets, they submitted their ratings and participants were debriefed. And if they needed if they got triggered or in some way moved by the discussions, upset or anything like that, then we were there to offer support for anyone that felt that way. Fortunately, nobody came out feeling like that, so it worked out good. The preparation for the first stage. First, Dr. Johnston and our research assistant went to Grant County and went to the the farmers market and the commons and the local Democratic and Republican parties, and they solicited for at the public libraries, and they solicited for participants. So those covered a pretty wide swath of participants, from Hispanic to Caucasian, from young to old. We try to get everybody from as wide a variety of people to have a fairly homogeneous group participating in this. The focus groups, what we found was everybody favored the overdose prevention programs above all else. So the overdose, to refresh your memory, the overdose prevention programs I believe they were focused more on saving lives, but they consistently rated the images more favorable than the others, the other names and descriptions for the OPPs and the SCSs. So according to the chart, you can see the name is on the first column. Descriptions, those are the descriptions of each packet. And then the images, those are the images, which I'll show you in a second. And then I combined all the statistics together for the final totals. So we have the OPP, the SIFs, and the SCSs. Participants favored the theme of saving lives above all else, which to me, I wasn't entirely surprised, but I thought we would have more of a conservative group than we did. The second phase, the online survey, also in 4 steps, similar steps. Participants read a briefing. They signed off on a consent. It was through SurveyMonkey, so it was all pretty much electronic, and they were able to do this in confines of their own homes and so forth. So it was a very different setup than the first part. But what's important is that the results came back similar in both of them, despite the differences. So in the second step, we have the program name description representing conceptual framings presented to the participants. Participants are asked to rate their degree, again, just like the first one, and respondents, they were cued to submit their answers, followed by a debriefing, very similar to the first one, except that it was done online, and the homogeneity was guaranteed by SurveyMonkey, and that's why we went with SurveyMonkey, because they offered some guarantees that prevented people from retaking the survey, and they guaranteed fresh panelists, and there's a number of different things here that we chose SurveyMonkey. They monitor for survey bots. They routinely perform panel calibrations. They guarantee access to pools of more than 10 million U.S. citizens. That all of those were appealing points. SurveyMonkey came up with slightly different results. As far as the names concerned, the descriptions, images, and then all combined were similar to the focus groups. However, the names, I don't quite understand exactly why the names were still figuring out why they didn't rate the names similarly. However, in this particular one, we added the harm reduction centers. I didn't include that in the final totals because it wasn't asked of our participants in the focus groups. So to keep the results pure, I decided to go ahead and run my totals on just the OPP, the SIFs, and the SCSs. Well, what I found interesting, particularly about the SurveyMonkey crowd, was that 56% of the respondents felt that people turn to substance use due to stress and trauma. And we know that is actually true, that trauma, especially childhood trauma, is a major contributor to risk factors for addiction. 50% of the surveyors or the participants knew someone that had lost or nearly lost their lives to overdose. The majority had never witnessed any public injection of drugs, and 22% admitted to having had to seek emergency care for somebody they suspected was overdose. Roughly equal amounts of men and women, and the age was about evenly divided at 60 years old. These are important because what we speculated was that people who had more interaction or more experience with opioid overdose and drugs and addiction would score differently. We figured they would score higher on OPPs, but it turns out that it didn't really matter if they did or didn't. They still scored fairly high, because most of the people in the focus group also scored high on OPPs, but they didn't have nearly the experience that's being conveyed here through SurveyMonkey. Here, these are the images that were highest rated. In the top right corner, you can see that our main selling point was stop the spread of HIV. Obviously, that's a medical issue. Then the statistic I told you about earlier, 0 fatalities reported. Well, that's another health issue. And then thirdly, the OPPs, people more likely to get into recovery, and OPPs save lives. So all three of the highest rated images are directly pointed to saving lives. People weren't concerned about the scientific background. They weren't concerned with the safety of their communities. They wanted to see lives saved. They wanted to see their families. They don't want to see families die. They don't want to see their members, their close loved ones die. Then here I combined all of them together. The harm reduction center, of course, I excluded from this graph temporarily until we could figure out how to incorporate that. The overdose prevention programs, as we can see, all the focus groups and the surveys all scored very high on OPPs. All combined, everyone scored high on overdose prevention programs. Obviously, if we're going to frame this to the public, then we should probably frame it as an overdose prevention program, and we should probably do it from the slant of it being a health consideration that can save lives. That's what, that's the gist of this research that we have so far. However, I'm constantly reviewing all this in my mind and thinking of ways to change it and add and subtract and modify this research. So I'm trying to talk Dr. Johnston into doing a second round, but I don't know if she'll be up to it or not. So we'll see. again, like I pointed out earlier, these statistics are valid because the phase A and the phase B were very different. One was quantitatively focused and the other was qualitatively focused. However, the results came back almost identical between both. And so in the realm of science, we would say that that's statistically valid because we're showing that the consistency between different variations. So, and then my final conclusions, most of which I've already gone through. So, like I said, the House Bill 123 here in New Mexico, that was framed as an overdose prevention program, and that made it all the way to Senate before it died. And I suspect it was COVID-19 that had everyone distracted, and that's why they didn't hear it. It's not that it wasn't voted on. It just, or not that it lost in votes, but it just was never heard, along with a lot of other bills that didn't get heard. So we'll try it again next year and next legislative session and see if we can get things happening. And that's all I got.
Thank you so much. A round of applause for him.
Thanks.
Virtual applause.
Virtual, yeah. Tap your microphones.
Thank you. Scott, do we have time for questions, right?
Yes, we have a little bit of time. Yes.
Okay.
I can ask a question.
Yeah, is it for me?
Yeah, Brian, it is.
No, I don't know if I'll answer it.
Yeah, I know that, back in the day, this methamphetamine didn't have fentanyl in it. And I do know that people consume it in two ways, well, three ways perhaps, but two ways would include injecting and smoking it. If there's more and more fentanyl in this drug, does smoking it, could that kill someone if they're smoking speed that has fentanyl in it?
We're not entirely sure at the moment. I've looked into that very briefly because I was wondering if you can even just smoke fentanyl. And I believe, if I recall, the residue that's left behind from fentanyl is very different than they are. That's what's encouraged. The idea is, hey, you know what? If you're going to use drugs, then come here. Because if you're here, we can save you. We can't save you on the streets. We can't save you in an alleyway or a bathroom or anywhere. But if you're here and we see you going out, then we can give you the Narcan. We can do medical, whatever we need to do medically speaking to revive the person and save their life.
Thank you.
Mm-hmm.
I had a question. So this is, of course, very important research topic. Fentanyl is, of course, like you were saying, increasing in popularity in terms of being used to cut a variety of drugs. But what spurred your interest in it? Why did you jump on the project originally?
To be quite honest, I have a lot of personal experience with addiction, and let's see, this past October will be 12 years that I've had clean and sober, and so that alone is enough to be the impetus for me or stimulus to pursue psychology and drug and alcohol counseling. So yeah, I've got a lot of personal history with it.
That makes sense entirely. I actually recently a relative of mine passed away from fentanyl overdose. So this is incredible to see that it's being pursued. Yeah, and I'm pretty open about it because it's becoming something that is very normalized in society these days. So, like yourself, somebody. Just about everybody knows somebody that is either struggling with addiction or has come close to death from overdosing. Yeah, I appreciate all of your work. It's profound. Yeah. Thank you.
Thanks. Yeah, thank you.